This rolling. Okay, unlike put it this way, rather than having to do capillary blood gases, which is, first of all, poking a little baby is not nice. It just leaves you feeling bad every time you end up doing it, especially if you're using a manual, not stylet, that's what I'm looking for there, where you puncture their finger or their heel. The beauty of having a neonate is that you have a umbilicus that is just basically now been cut off, and in the very early stages we can go ahead and catheterize the umbilical artery. The umbilical artery was the artery that was carrying venous blood back from the baby back to the placenta. Now it's a nice big artery that's sitting there, and by threading the catheter in, I can go ahead and use it as a source for administration of medications as well as sampling of blood. That's really the primary reason we end up using it. I don't care that you know the sizes that we would use as far as the catheters, but think about how big you guys probably don't know how big 5 French is. It's dang small. Okay, and a 3.5 French is even smaller as far as your diameter of your catheters. But when we do that, we can go ahead and sample blood from there, and it's our arterialized blood. It's arterial blood. The catheter itself is threaded up. You can see we're going here, we're catheterizing the umbilical artery, and as it's entering it back up, it goes back into the descending aorta. If we're going to go ahead and use this, we have to remember, we'll talk about this in the fall. Well, we won't, but somebody will talk to you about arterial line sampling in the fall. And when you have this catheter inside, let's say I want to draw blood from this point here, which is at the distal end of where that tip of that catheter is, all of this stuff here has heparinized fluid within it. So the first thing I need to do is pull that heparinized fluid off, waste it, and then go ahead and get my blood sample. Does that make sense? Otherwise, I'm drawing blood back that's got a lot of heparin in it. It's going to alter your results and not make them accurate. So we're going to go ahead and get rid of that heparin. Whether or not we dispose of that blood or just recycle it back in again is kind of protocolized by each place, but then we go ahead and draw off an extremely small amount of blood, because blood gas analyzers don't need to have 3 milliliters of blood, even though I don't know what Mary said we ended up needing to draw, but you'll see people who draw a whole lot of blood. It's like, you don't really need that much. So enough to make that heparinized, enough to make that heparin not come into something where it's going to alter the results. And in many cases, we have pre-heparinized syringes that we're ending up using, but we can use as small as a half milliliter of blood. Obviously, you don't want air to be in that line because you're going to flush some of that back in again, and the last thing you want is have an air embolism inside the baby. And after we're done sampling our blood, we'll go ahead and flush that line. And what you'll learn in the fall is basically how to use, they have a stopcock system where it's a 3-way stopcock. You turn it this way, turn it that way, and we'll, again, cover that another day. Go ahead and roll the sample, mix it up. In most cases, we're not putting things on ice. We're sampling them quickly. Where they're located at the tip of that catheter is about the 3rd or 4th lumbar vertebrae if we were to look on a chest x-ray. So you can kind of get an idea how far up into the descending aorta it ends up going. Lots of problems with them. They're not benign. Probably the biggest one is infection, or a clot developing on the tip of the catheter, breaking loose, and now you have it traveling down to the lower extremities with reduced circulation in the legs and perhaps even some blockage. And there's also one where we end up having problems with circulation to the intestines. And one of the disease states we'll talk about when we talk about the next module is something called necrotizing enterocolitis, and it's very tragic, some of the outcomes that ends up happening. Remember, this is postductal blood. It's after the patent ductus arteriosus, which is approximating the arch. Right after the brachiocephalic is typically where the PDA joins into the aorta. So in this case, we are looking at postductal blood. So somebody who does have a patent ductus arteriosus, we're not going to get a true reading on that. We would need to look at something on the right side. Okay. Don't leave them in for prolonged periods of time because infection sets in. But they can do in the meantime great job as far as monitoring of blood pressure, sampling of blood, infusing of fluids. It's a great IV source, if you will. And this is kind of what the little stopcock system, and again, I'm not going to worry about that right now. We'll talk about that later in the fall. Skincare. We talked about these babies, especially the micropreemies, not having a whole lot of skin there, basically. Their skin is transparent. You place any adhesive onto it and remove whatever you're placing on there, the skin can often come off with it. So you gotta be very, very careful because those outer layers are very easy to remove, and then you got a bigger chance of infection there in the process. So we go through all kind of pains to place things like probes and EKG electrodes and pulse oximeter setups. In fact, with a lot of stuff, we, as much as possible, try to use Velcro wraps as opposed to actually placing something onto the skin with an adhesive. Obviously, going to use mild soaps to wash. When we go ahead and try to remove, we'll use citrus oil-based adhesive removers. So, kind of like what you use with trying to get adhesive off of something at home. It's kind of a similar idea. We go ahead and treat the surface of the electrode where the adhesive portion is, and then it removes that process a whole lot easier. If there is damage to the skin, obviously you got to take that into account with some sort of probably an topical antibiotic to be able to manage it. Oxygen, I'm just going to briefly talk about because I know Mary's talked about some of these applications. In theory, in the emergency situation, you can do free flow oxygen just by holding oxygen in front of their face. Problem with that is a lot of babies, especially again the micropreemies, the real problem ones, are sensitive to cold. We talked about that last time. So you got to be very, very cautious and judicious if you're going to do free flow oxygen in that fashion. When I was young, every neonate was in an oxygen hood. That was kind of the way that we delivered oxygen was with an oxygen hood. Now, because they're obligate nose breathers, you'll see high flow nasal cannulas used more and more, where I can go ahead and titrate not only the liter flow, but I can titrate the FiO2. Okay. I think Mary's talked about the high flow nasal cannula, and they make nasal cannulas down to a micropreemie level. As far as airway clearance techniques, I think, is Mary doing some kind of a seminar on that? What's that? Okay, then it's not a big deal, is it? There you go. There's a ton of different ways that we can use to clear secretions. Where you'll see this used is in situations like cystic fibrosis or patients with bronchopulmonary dysplasia, which you don't know what that is yet, so you'll see that later on. Lots of secretions. And there's a multitude of devices out there. Everything from something as simple as just tipping and positioning and using external chest percussion through elaborate pieces of equipment, vests and whatnot that'll shake the living snot out of you. We've gotten conventional. We can just take a little mask that we would use for resuscitation purposes, put a little tape over the end so it has basically air trapped on the inside when you compress with it, and that's a percussor. There's also elaborate CPT percussions where they're attached to a little stick and you just wrap on their little chest. And you got to think about how big this has to be. It's about the size of a dime, okay? Because that's about the space that you have to work with on a neonate's chest. Now, let's go ahead and make sure we're clear on this, because this is important. Put a star by it. This next topic. First of all, a distinction between CPAP and PEEP. I don't know to what extent Jeannie or Mary may have talked about this previously, but I'll give you my take on it. Whenever you have an elevation in baseline, where during the expiratory phase, there is always a small amount of positive pressure being applied. If the patient is breathing spontaneously, i.e. there's no mechanical ventilator associated with that breath, there's no positive pressure on inspiration, we're going to call that CPAP. If there's a positive pressure associated with the inspiratory phase, I'm going to call it PEEP. What's the difference beyond that? Nothing. It's semantics. So you sitting here, I could apply positive pressure to your face, and that would be CPAP. So in other words, what you're doing is you're creating a baseline. Come here, you. You're just problematic. You know? Okay. Oh, I went down. I wonder why I'm not going in the right direction. You got to press down. So here's an example of a CPAP breath where I basically have just increased the baseline to a higher than normal atmospheric level. And as I take a breath in, it goes slightly negative. As I exhale, it goes slightly positive. Simply put, CPAP. Spontaneously breathing around an elevated baseline. Why would I want to do that? Because I have a refractory hypoxemia. By definition, when I start seeing FiO2s greater than 50 to 60% and still profound hypoxemia, that's telling me that I got a refractory hypoxemia. It's refractory because the alveoli are collapsed. No matter what you do to FiO2, it ain't going to help you, at least not appreciably. Yes?
So we're doing CPAP to improve refractory hypoxemia?
To treat refractory hypoxemia. Yes?
What is refractory?
Refractory means it ain't working. What should happen when you turn up the FiO2 knob? PaO2 should improve. If it doesn't, it's refractory. What causes refractory hypoxemia is that I have a collapsed alveoli. If I have an alveoli here that looks like this, and one that looks like this, and they both have blood flow going by them, this is going to have a PO2 of about 40 coming in, and 40 coming out. This is going to have a PO2 of about 100 coming out. When they mix together, it's going to be something less than 100. How much less? It depends how many of these guys on the left-hand side you got. You got more of them, more of a profound hypoxemia. Jeannie's going over this, right? Yeah, rat bastard. What are you doing with her? Is Mary? What do we call those kind of units? Shunt units. I think we talked about them last fall. They're areas where you have perfusion but no ventilation, or perfusion that's well less than ventilation. Said that wrong. Where ventilation is well less than the amount of perfusion you have. Yes?
What if we use nitric?
We're not going there yet. Hold on to that thought. That's one way we can do it if the conventional mechanisms don't work. Our first approach is to get that left guy reinflated. The best way to get him reinflated is to apply positive pressure during the expiratory phase. Don't let them collapse shut. We're going to use CPAP therapeutically to reestablish the FRC. Oh, good God, I used a lot of words there. Let me say that again. We're going to use CPAP, or PEEP, to reinflate that alveoli and keep them open. What's the definition of FRC? Please don't make me cry. Yeah, it's called functional residual capacity. What is it? It's the volume at the end of a normal exhalation. So if somebody has collapsed alveoli, what's their volume going to be like at the end of a normal exhalation? Lower. They're going to have a loss of FRC. PEEP, CPAP, reestablishes it. I think I might have done this with you before. I'll do it again with you. Take a breath in, breathe out halfway. Take a breath in. Oh, that doesn't feel good. Because we're jacking with your FRC. The problem with these people is that they have a loss of FRC. Be almost like blowing out entirely and only taking a little bit of a breath in from there. That's just not comfortable. Okay. Examples of that are atelectasis. And what we're going to find, kids with RDS have massive atelectasis, have massive amounts of shunt units. The only way to fix it is to reestablish. You could put them on 150% oxygen. You put them on 100% oxygen, ain't gonna make a difference. At least not appreciably. Fair deal? Okay. Another use of CPAP PEEP is for apnea of prematurity. We talked about that previously. These little babies that are born who aren't neurologically developed, and they have periods of apnea, different than periodic breathing, but periods of apnea, and we can treat it with CPAP. Why it works, we're not entirely sure, but hell, it seems to work. So that and a little bit of caffeine, give them Starbucks, and they're just fine. Cool? Okay. How do I deliver CPAP? Well, if they're on a ventilator, it's a whole lot easier. I mean, then I have PEEP set up there, and I can go ahead and use it that way. Most children, though, have, because they're what we call obligate nose breathers, they breathe primarily through their nose, not through their mouth. We can apply positive pressure to the nasal passage and create CPAP. Over the summer, we'll spend a little bit of time talking about non-invasive ventilation, or something we're going to call biphasic positive airway pressure, or BiPAP. And that's basically where we apply with a mask, either a nasal mask, full face mask, Jason mask. Basically a situation where you have positive pressure being applied both during inspiration and expiration, non-invasive ventilation. A lot of the kids that we can get by with just nasal. Nasal CPAP. What we need is an air and oxygen source. Now you're going to notice this looks very familiar to something Mary talked about when she was talking about the high flow nasal cannula system. Same exact system with a little bit of a twist. So we need an air and oxygen blender. So I want to be able to have a precise amount of flow of oxygen with this precise FiO2. I'm going to have a humidifier. Because I have a humidifier, probably need to have something to drain the trapped water that may be in the circuitry. I'm going to have some kind of a mechanism to apply to the CPAP to the patient. And one that I'm going to modify and show you is the nasal prongs. It's probably the most common one that would be utilized. I'm going to have a pressure manometer to monitor how much CPAP I'm applying. Because too much is as bad as too little. Some kind of a device to generate the CPAP. And I'll hold off on what I mean by that in a second. A reservoir bag system, which is a little bit different than what you currently have, and perhaps even a low pressure alarm to detect when something's gone wrong with the system. So here on the left hand side you can see a nasal prong. These little prongs fit into the little baby's nose. These prongs hook up to my circuitry. And now just by placing it at the proximity of their nares, I can go ahead and apply positive pressure. Because they're obligate nose breathers, as they exhale, they're going to face some back pressure. Think of Fido sticking his head out the window as he's going down the street of the car, right? That's positive pressure. He's breathing spontaneously and getting this blast of... No, he's not hypoxemic. Maybe he is. But it's basically a similar application to the pattern. So let's take a look at what this is involved with. So this is a CPAP system. You may want to put a little star by this. Not that I'm going to have you diagram this or anything stupid like that. Thank God for that. So what do we have? We have a blender. Taking wall oxygen, taking wall air, blending them together to get a precise FiO2. Hooked to that, I have a flow meter so I can regulate flow. Unlike a high flow cannula though, this is going to be attached to a reservoir bag. So there's basically excess amount of flow that is always available to the system. Part of why we end up being able to maintain a constant pressure within the circuitry is that I got a lot of flow behind it. If they draw in of air or if there's a small leak, there's enough there to keep that flow going through the circuitry. Okay. There's a one-way valve that allows gas to move from right to left, but not from left to right. So when they exhale, there's only one place for the gas to go, and I'll show you that in a second. Humidifier. Dry gas out of the wall is not pleasant. You want to have, especially at higher flows. An anti-asphyxia valve. An anti-asphyxia valve that says if this flow meter should come loose, that means there's no flow going to the bag, there's no flow going to the humidifier. Ooh, that could be bad for baby. So I have a one-way valve there that allows them to breathe through the atmosphere. Because this is a closed system. Okay. So the purpose of the anti-asphyxia valve is to allow for them to access atmospheric air should the system fail for some reason or other. Going through my inspiratory limb to my patient, and they are able to breathe in and out through there. I have a pressure manometer monitoring what the pressure is at that point. So as they draw gas in, you're going to see a drop in airway pressure, just like you would expect to see on a CPAP breath. Then as they exhale back out again, there's a small positive pressure that is created, and you have that, in essence, sinusoidal waveform that's elevated to a higher baseline. Why is it elevated to the higher baseline? Because I have something downstream that creates positive pressure. And there's multiple different ways we can end up doing it. This is called a threshold pressure valve that says that I just blow against this. Simplest method in the world, take this tubing, stick it under some water. The depth that it is below the water is how much CPAP you end up having. Have it 5 centimeters below the surface of the water, you have 5 centimeters of CPAP. Now how cool is that? Because as I'm exhaling through there, it's got to go through that water before it bubbles out. That depth of that tube dictates how much CPAP you end up having. Now, obviously that's not a very clean system because you can knock over the water and I lost my CPAP. So there's different ways that we can end up doing that mechanically. Through springs, through weighted balls, through all kinds of different things. Okay. I believe Mary talks about the down CPAP flow generator, and when she gets to that, it'll kind of make a little more sense. Consider that just a magical black box that creates the desired amount of CPAP that you have. Got a gist of what the system looks like? It's kind of like you're sitting there bored one afternoon and having nothing better to do to put together. Now, I will tell you that there are machines that will do this automatically. A whole lot easier. But if push came to shove and you had to put it together yourself, kind of what you've been used to seeing so far with the high-flow nasal cannula system, just adding a couple other pieces in there. All right. 2 conditions. Big star, exclamation point. 2 conditions. 1, your pressure in the circuitry is less than you would anticipate it's supposed to be. I'm supposed to be on 5 of CPAP, I'm only reading 3. They're oscillating around that 3 instead of oscillating around 5. If I don't have enough pressure, the most logical thing is I got a leak. How would? So make sure everything's tight. The other answer, and this is the answer in more often than cases, is turn up the flow. The flow is insufficient. If you don't have enough flow going to that reservoir bag, you're not going to have enough flow to keep the pressure within the circuitry high enough to be able to keep my CPAP where I want. Could be that my prongs aren't, you got 2 prongs, right? One going to his eye, one going to his nose. No, both got to be going to his nose. And I've seen the nasal cannulas like that too. Or the baby is crying. When they're crying, they now open it up to the atmosphere and they lose their CPAP. The rat bastards. Give them a pacifier. Should have been. Loss of pressure, leak, or low flow. Other situation, too much pressure. Duh, maybe there's an obstruction. Maybe there's something that's causing that nasal prong to be blocked up by a bunch of secretions. Not that babies would ever have nasal secretions, mind you. Could be something where that exhalation valve, that thing that's creating the PEEP is faulty. Or it could be that I have too much flow. Too much flow will actually lead to an elevation in baseline pressure. So it's a dance that you're going to do between too little and too much. You're going to watch the manometer to be able to determine if you got the proper amount of flow. Make sense? Okay. Guaranteed you'll see a question or two related to CPAP. It's an important concept. Okay, how do I monitor? I think Mary probably had talked about these previously. Transcutaneous oxygen, transcutaneous carbon dioxide. They're good for trending purposes. They're not good necessarily for knowing what's going on a moment-by-moment basis, because there is some loss of oxygenation and carbon dioxide levels. There's some alterations in them as you're measuring them. You should know it's a Clark electrode for the PO2, a severing house for the PCO2. And we're warming these sites to something greater than body temperatures to increase perfusion to that area to make them a little more accurate. And because we're warming those sites, we need to change the sites, otherwise the little baby's skin will get burned. I already told you that their skin is thin enough as it is. So they're really prone to it. Alternatively, we have pulse oximetry. Again, from Lambert-Beer's law, we know about that photospectrometry. Plethysmography. Lots of problems with the pulse oximetry, however, although babies typically don't have nail polish. But certainly darkly pigmented skin can make a huge difference. Motion. Oh, good God in heaven. Maybe not so much neonates as it gets to larger infants and certainly pediatric patients. One of my ex-students described it as trying to put a Band-Aid onto a worm. You can get the general idea. There's also a lot of ambient light that is present there. They're also in a situation where they're perhaps cold. And as they get cold, their perfusion shuts down, so the accuracy of the pulse oximetry goes away. One other aspect of pulse oximetry, and we'll talk about this when we talk about the disease retinopathy of prematurity, If my saturation is 99 or 100%, what's my PO2? Something probably greater than 85 or 90. Could be 90, could be 300. I don't know. Going to have the same saturation. Well, this becomes very, very, very problematic. So, good technology, but you got to know what it's able to do. Okay. I think Jeannie talked a little bit in Module B in 1140 about mechanical ventilation. Obviously, apnea is going to be an indication for it. We're talking more than just apnea of prematurity here. We're talking about something a little bit greater. Ventilatory failure versus oxygenation failure, both of which are indications. We know that in the adult world, at least, we control CO2 by regulating frequency and tidal volume. And we kind of do the same thing in the neonatal world. We control PaO2 by simply adjusting FiO2, but once we get above 50-60%, it's kind of a cutoff to say, yeah, maybe we better look at applying some PEEP or increasing the PEEP, or doing anything else that'll alter the mean airway pressure, the space under the table. Make the table legs higher, make the table longer, however you want to end up doing so. So I want to alter my blood gases, and I'm going to do that by altering minute ventilation to control my CO2. We don't set tidal volume typically on infant ventilators. It's usually not something which is monitored by, or that is controlled by tidal volume. Because we don't have a tidal volume now. We're using a different type of ventilator, a pressure-based ventilator. And we can also use the rate to alter the minute ventilation. It's our primary mechanisms by which we're going to control CO2 by controlling alveolar minute ventilation. You may want to put a little star by this. Did Jeannie talk about pressure versus volume ventilation? A little bit? Okay. Two different approaches. I can fix my tidal volume, have pressure variable. Going to be dependent upon compliance, resistance, and work of breathing. I can set my pressure, have tidal volume, and flow variable. Which is better? Yes. Depends on how you use them. You can be a moron using either. You can be a genius using either. You just got to know what you're doing. Okay. Typically, most of the ventilators we're going to see in the neonatal world are what we're going to call time cycle pressure limited ventilation. Oh my God, what did he just say? Yeah. We fix the amount of pressure. We fix the amount of time that pressure is exposed to, and we monitor the tidal volume that it generates. So I'm going to set it to a pressure that's going to give me a tidal volume right around 5 milliliters per kilogram of body weight. Now notice I didn't say the ideal body weight, because in a neonate, their body weight is their body weight. They're so damn small. So if I have a 2 kilo kid, I got a big kid there. Let's say I got a kilo kid. I'm going to have him trying to get a desired tidal volume about 5 milliliters. Think of your syringes. Think how big 5 milliliters is. Ain't a lot of room for error. All right. I'm going to have inspiratory time somewhere in the order of 0.3 to 0.5 seconds. So your respiratory rates are probably going to be in the 40 to 60 range. Probably about a pretty fast little rate there. And we're going to adjust FiO2 and baseline pressure to target my oxygenation. So the first two kind of give us an idea, actually the first three, kind of give us an idea of PCO2 management. Mainly the first and the third. The I time, the FiO2 and the PEEP really more collide to mean airway pressure and therefore to oxygenation. So if my CO2 was higher than I wanted it to and they were a little bit acidotic, I would probably try going up on the rate. Maybe go up on the pressure, but I got to be careful there because I don't want to go too high. as we'll find higher airway pressures pose problems.
So is the 0.3 to 0.5 and the 40 to 60, is that what you're going to set it to, or is that
Yes.
what it turns out?
Those are normally where you end up starting off with.
Do you set that, or does that happen because of the pressure that?
No, we set it. We set the time, we set the rate. Obviously, if I'm setting a respiratory rate, I'm determining a total cycle time. Oh no, not that formula, Rick, please. This is where it comes back to haunt you. Okay. If I have my rate set at 60, I have total cycle time of 1 second. If I have 0.3 seconds of inspiratory time, let's have 0.7 seconds of expiratory time. They have roughly a little bit more than a 2-to-1 ratio. 2.3. Make sense? So if those formulas are really cold to you, you may want to go back and relook at them. So this is where it's going to start coming back to play with us. I think there's some self-assessment stuff in this module that makes you go back and relook at that again. And I think Jeannie talked about this one as far as the area under the curve. Now, these pressure-based ventilators are a little bit different because the pressure that we're setting is a fixed pressure. Here's my baseline, here's my fixed pressure. If I go up on my baseline, what do I do to the distance between them? I make it smaller. What's going to determine tidal volume is that delta pressure, that difference between the peak and the baseline. Let me say that again. If I take this baseline and I make it bigger, I shrink the difference between the two. What's going to determine tidal volume is that difference. So you potentially, just by making the peak better, I now made the tidal volume worse. Maybe that's what you want to do. Maybe it's not. But you got to think about it. Okay. Unlike pressure ventilation in the adult world, which is always referenced to the baseline pressure, this is different. These are two separate pressures. And this concept will come back to us in the summer. Okay. What determines tidal volume? The difference between the peak pressure and the baseline pressure. What I'm going to call delta. Or if you see that. That's the difference between the peak and the peak. Called delta. Not delta delta. That's all it's saying. Delta determines tidal volume. The change in pressure. How much pressure change do I have? Same thing is true as if I change the upper one lower or upper. If I raise those, I'm going to change the amount of delta you have. I'm going to change the tidal volume. Bigger pressure difference, bigger tidal volume.
So if we increase tidal volume,
We don't set tidal volume.
So if we increase PIP, we would increase tidal volume.
Yes, you would,
Okay.
assuming you left the peak the same place. So let's say I had a situation where I wanted to change my oxygenation, but I like my CO2 just fine, thank you. I'm on a baseline pressure, let's say a 5, and I'm on a PIP of 15. So my pressure is going from 5 up to 15. What's my delta? 10. My PO2 is lousy. I want to make that PO2 better by increasing mean airway pressure by raising the baseline. I want to go to the baseline now from 5. Let's go to 7. If I did not change the PIP, What would my delta change to? 8, right? So if I wanted to keep the delta the same, what would I do? Increase the PIP by 2. Keep my delta the same. It's a little bit of a different focus than we have with the adult world. And it gets really tough when you're working adult one day and you're going to NICU the next day and you have to go, oh yeah, oh yeah. Pay attention to delta. Oh, they're there. How friendly. Don't look at me in that tone of voice, Katie. This is where they're going to come back to play. You'll visit it again over the summer. All right, let me go through these other applications, because these are ones that we use when things aren't working well. Do we need a break, or are we okay? Let's keep going. The four that I want to talk about are high frequency ventilation, nitric oxide, surfactant replacement, and ECMO. These are what we use when things aren't working well conventionally. So I got a baby on a mechanical ventilator. They're on maximum settings, and I'm still not cutting. They're still profoundly hypoxemic. They're still profoundly hypercarbic and acidotic. High frequency, by definition, is considered anything over 150 breaths per minute. And it gets so fast that we don't even talk about breaths per minute, we talk about hertz. Where hertz, capital H, small z, is defined as 1 cycle per second. In other words, 60 cycles per minute. So with high frequency ventilation, the latter two are what we typically end up using, either a high frequency jet ventilation or high frequency oscillatory ventilation. We're talking on respiratory rates that are just super high. Star, exclamation point, important point. We use high frequency oscillatory ventilation typically for kids who have oxygenation problems. Okay, then here you go. We use this one, O2. We use this one, CO2. There, inner discussion. High frequency jet ventilation is usually used for patients who have an inability to adequately clear CO2. Usually this means that they have some kind of a leak. And when I say leak, I mean physiological leak. They have a tear in their bronchus. Okay. There's some other reason why I can't ventilate that patient. High frequency jet ventilation functions well there. Most of the kids we're going to encounter who do not respond to CPAP and PEEP therapy, first thing we'll kind of look at is high frequency oscillatory ventilation. That's what that slide will say. Okay. You have this one? Diesel, Pete. Okay, I'll have to send this one out. Let me just put it in a nutshell. We're talking about respiratory rates somewhere on the order of, I don't know, 5, 6, 7 hertz. How many breaths per minute is 6 hertz? 360. 60 cycles per second is 1. So 6 times that is 360. 360 breaths per minute. Right? The way that we tell that this is working well is we use what is called chest wiggle. Chest wiggle factor, that's right. You watch the kid's chest and you turn the frequency up until you see them vibrating. I ain't kidding you. At that point, you know you have reached the resonant frequency of their lungs. Who's pushed a kid on a swing? We all have, right? Can you get to a point when you're pushing them where you just got like one finger? And they'll just keep on going with no effort on your part. The amount of force that you're applying to that moving object is almost negligible. That's what's happening in the lung. I'm causing that lung to vibrate without applying excessive pressure. And that, believe me, that's our goal. These lungs are very fragile. Put too much pressure, you blow. So we vibrate these kids by having this oscillatory breath until we get to this point where we see their chest wiggle. Oh, there it is. And they breathe spontaneously around that wiggling point. Okay? What we're doing is we're basically increasing their mean airway pressure up with that breath. Now the tidal volumes that this thing is generating could never support life. If their normal tidal volume is 5, their volume that's being moved with that wiggle is maybe, I don't know, quarter cc. It's less than dead space. How the hell do they breathe? How the hell does a dog breathe when he pants? Tidal volume is less than their spontaneous tidal volume. It just does. How it works, you don't need to know about right now. But there's a different theories on how they breathe. It's totally different than when we're dealing with the way that we conventionally ventilate, bulk movement of gas in and out of the lungs. Doesn't happen in these cases, but it does happen. Oxygenation problems drive the mean airway pressure up until their chest is wiggling. Keep the frequency going higher and higher. Or the amplitude going higher. How much that piston's moving back and forth. Got the gist? Okay. Kind of like a kid on a swing. The best analogy I've ever heard from you. You're applying minimal amounts of pressure to accomplish good mean airway pressure. Drive mean airway pressure up, what happens to oxygenation? It gets better. That's a general rule. Space under the table, right? Jeannie did talk about that, didn't she? Yeah. Okay. This is what it looks like. A whole lot of knobs. No, actually, there's only a handful. It's a very simple box, but a very ugly looking setup. But right now, all I want you to know is high frequency oscillation, oxygenation status. Looking for the chest wave. There's some other really bizarre stuff in using it. One of which is that as you go up on the respiratory rate and make the frequency higher, you actually make the CO2 higher. It's opposite of conventional ventilation. But for right now, don't have that. This is the jet ventilator, the Bonnell jet ventilator. There's one brand of each. We'll talk about a closed market. Jet, CO2, oscillatory, O2.
What about CO2 to reduce the CO2 for using that to reduce?
Yeah, and it's really used in the presence of airways, where I got a tear someplace in the system. And whatever volume I'm trying to deliver to the patient, to the lungs, aren't getting it. 2, nitric oxide. It's a specialty gas that we can utilize through a conventional ventilator circuit. And what you need to remember about this is that it's a selective pulmonary vasodilator. It's going to cause pulmonary vasculature to vasodilate, to relax, to not be so constricted. We use it in situations where we have high vascular resistance in the presence. I think I talked about this before, but one of the best ways to cause your pulmonary artery pressure to go through the roof is to become hypoxemic. Patients that are hypoxemic, especially long-term hypoxemia, develop pulmonary hypertension. increased PVR. The PVR becomes so high in some adult patients and some pediatric patients, like cystic fibrosis, that they end up having right heart failure. The right heart becomes difficult to pump the blood through. We call that cor pulmonale. Blood then backs up into the periphery. We have all those manifestations with hepatomegaly, increased JVD, etc., etc. How do I fix it? Nitric baby. Selective pulmonary vasodilator. Now notice the amount of gas that we end up using. We're talking about not milliliters, we're talking about parts per million. So it only takes a little bit of this to cause all kinds of wonderful things to happen. One of the downsides to any nitrate, be it nitroglycerin, sodium nitroprusside, nitric oxide, it causes methemoglobin. It causes that ferrous to become ferric. Remember back then? That's 1050, guys. I know I talked about it. All right, put a star by the picture because it's a great explanation. Situation A is a situation we have. I have equal amounts of blood flow going to two different alveoli, one of which is totally useless, one of which is functioning fine. What do you want to happen? Well, I would love to get an alveoli on the left back open again, but my CPAP isn't working. My high frequency oscillation isn't working to get that back open again. Well, how about if I inhale some nitric oxide? Where's it going to go? The guy on the right. It's going to cause the vasculature associated with that alveoli to vasodilate. Now all of a sudden all the cars are going to go to that alveoli. And screw the other guy. Because it can't get through because it's collapsed. That's how it becomes selective. It looks for alveoli that are open and causes the blood flow going to those alveoli to increase. Causes the blood flow going to the alveoli that are collapsed to be reduced. So I reduce my shunt. I reduce it not by inflating that alveoli, but by causing more blood flow to go to the guy that's good. In doing so, I improve oxygenation. Concept makes sense? This is a sweet one. Good news, it works wonderfully. Bad news, very expensive. Guess what? There's one company that makes the delivery system. I got to market. Yeah. Very, very short. I think I got a slide on this one now. Yeah, we talked about it. Again, causing this. The problem with it is that sometimes it's tough to wean, and you got to wean very slowly. So you go from this amount to this amount to this amount to this amount. Very tough. We've talked about surfactant, standard of care in premature babies. Prophylactically, we give it. Even if we don't see it, don't wait until they crump. ECMO. How many people have heard of ECMO before? Stands for Extracorporeal Membrane Oxygenation. And it's basically a heart-lung machine, but used outside of the OR. When you go, well, hopefully you won't go in, but when a patient goes in for open heart surgery and they're doing some major repair of the coronary arteries, well, they can't have the heart beating while that's occurring. So they divert blood to this device and stop the heart. Surgeon goes ahead and does his work, start the heart back up, take them off the heart lung machine. Okay. Same idea here, except we're not stopping the heart. But we are taking blood out of the baby and passing it through a membrane oxygenator. This actually is relatively new, but not relatively new. Okay. We're talking 40 years since we started placing babies on ECMO. Most of the pediatric units around, I believe Beaumont's is now up and running, but U of M has been probably the folks that have been doing it the longest. This is something that RRTs are trained on. You can become an ECMO specialist, where your shift is basically just working with an ECMO baby. One ECMO baby. And is how it's been described of 11 hours and 48 minutes of boredom and 10 minutes of actual panic. Because if something goes wrong, bad news. Robert Bartlett is what is known as the father of ECMO. And I'll show you a video here. See if I can find this. Because he's a pretty fascinating guy. Take 5. For you and who? Try this one.
So I'm going to learn mechanical ventilation in detail in summer.
Oh yeah.
It's just like over my head.
Well, you should have some basic understandings as far as how I control CO2, how I control load. Those kind of things is generally how what I do. Control minute ventilation, control the airway.
Right.
So for now, that's really all we expect to be at.
Yeah. Either you control pressure in the volume. That's all I get.
Well, we'll spend a lot of time on that one.
Yeah.
As far as, am I using pressure to accomplish a tidal volume? Am I using tidal volume to accomplish a tidal volume?
Yeah. Yeah.
We'll spend probably 8 weeks on it.
Yeah. Okay.
Don't feel like you have to have that all down pat now. You'll hurt yourself.
Did you see the crazy looks I was giving you?
Yeah.
I'm so freaking confused right now. That look? Did you see it? Oh my god. Yes, I am.
Not supposed to care.
Yeah, you're supposed to stop and be like, Susan, do you understand? Do you get it? This class would be hours if you really did that. Okay. I'm really confused on this.
Okay.
Super confused. I know that.
Delta pressure. Now this is one control. This is another control structure. Cool. This is different than the adult.
And like the difference between that would be okay.
So let's say my oxygen. I want to manage it by increasing the that's the average pressure. Airways are exposed to during the different. It is. You just gotta believe me.
Yeah, I'm trying to off breath, but all
Based on the state, if I make that oxygen and the air pressure better, so one way that I can make this better is by going off. As I increase P, increase it, now I have all this extra problem. I don't mind the same. Alright, let me show you a 5-minute video. The physician you'll hear here talking, hopefully the volume is working, is Dr. Bartlett.
Here we go. Everybody and family members are getting excited, just kind of getting used to the idea of being pregnant, getting used to the idea of having twins. And the doctor kind of said, what I see is a diaphragmatic hernia on your son. It was pretty heart-wrenching. We really didn't know how to feel. We didn't know how to react.
And then when they told us, possible CDH, we were like, well, what is that?
Congenital diaphragmatic hernia is a disease where the diaphragm is not fully developed. In my son's case, the intestines, the stomach, the liver migrated north to where his heart was originally located. So his left lung was very, very small. It was almost like a bud when he was born. We started hearing about ECMO when we talked with the doctors. The big name is Extracorporeal membrane oxygenation, but it pretty much is a machine that does the work of your heart and lungs for you.
ECMO refers to the use of a heart-lung machine which has been modified so that it can be used for days or weeks, even months of time, without damaging the blood.
Even when we discussed it, we're like, this machine is going to do what? This machine is going to save our son?
Because when he was born, they took him first to get him ready to go on ECMO.
And 2 minutes later after his birth, our other son was born, and it was one of the best and worst days of my life. So he was on ECMO, and he was on there for a few days. They came to us and said, you know what, your son's not going to be able to be taken off this machine yet. We're going to put him back on. Mind you, your son's going to have about a 5 to 10% chance of living after we put him on the second time.
We still had faith in that machine to pull him through it, and it did. It worked.
It makes you feel great, of course, to realize that you've done something or contributed to a bit of technology that's been successful in prolonging lives or saving lives. There's 60,000 patients, and here in our laboratory we're studying technology related to ECMO.
One of those projects, one of the most interesting, it's called the artificial placenta. So if the baby is born significantly earlier, very, very premature, you can keep this fetus alive at an age when that was just not even conceivable.
And what I've been doing in the lab for the past couple of years is working with the artificial lung So I was helping to test membranes that reduce clotting in the lung to make it more efficient, and now I'm helping to actually like redesign a new artificial lung.
Part of our good fortune is that we're here at the University of Michigan, where there are many undergraduate and graduate students who are interested in biomedical research. Some of them come to work in our lab, and this year we happen to have students who were on ECMO as newborns here in our own hospital.
I started off here at University of Michigan, which saved my life, and now that I'm giving back through this lab, so I've come full circle.
Our laboratory is financed primarily through research grants and on philanthropy. Donors, they understand that we have to keep the laboratory going between grants, and so we rely heavily on those supporters who support our laboratory.
I don't think he would have made it without ECMO.
We'll always have connection to U of M. As long as they're there, we'll always have connection. They're our family now. We owe the world to U of M. We owe the world to Dr. Bartlett. We owe the world to ECMO. This simple machine, this not so simple machine, we owe our life to. Seeing our son now the way he is, it kind of makes you forget, just for a split second, what he went through. We kind of tossed around names here and there and stuff, and after the first visit to the University of Michigan, we had seen a banner, a child, and he said, helping the victors. My husband, he kind of said, hey, well, what about Victor?
The odds were against us the whole way, but Victor fought, and so will Victor.
And Dr. Bartlett is one of the most laid-back, calm people you will ever come across. If you ever have a chance to hear him speak, he is just amazing.
Is that something that is outdoor maturity?
I'm sorry?
Is the problem
The congenital? No, it's basically, well, yes and no. Surgical repair, and then over time, whatever lung is there that's been underdeveloped will have some development, but potential is always there. And when we talk about congenital diaphragmatic hernia, we talk about disease states. It's a pretty neat one to say the least. Okay, go back here and restart this. So that's rolling. And I'm not going to expect you to know much about ECMO other than we're taking blood out, we're running it through an oxygenator, we're putting it back in. Okay. Sometimes we can do this and rest the heart. Sometimes the heart is also maintaining a good blood flow. Lots of indications, and we'll talk about these as we go along. So patients that are profoundly hypoxemic, not resolved by anything else, ECMO is an option that we end up having. Sometimes, depending upon the situation involved, we'll go to that earlier, like CDH. Sometimes we'll try other mechanisms in the process. Have to be a reversible pathology. Can't have, and they don't usually do it for kids who have what we're going to call intraventricular or intracerebral hemorrhage. Big bleeds to their brain, because neurologically, cognitively, they probably will not have good outcomes. One of the aspects of an ECMO circuit is that I got to have that blood flowing through and it can't clot. So that means that I'm putting a lot of heparin into the system to prevent clotting. But that heparin's getting back into the baby. So there's a fine line you got there between keeping the blood moving and causing bleeding happening. One thing I would like you to know is the oxygenation index. Of course, because Rick likes formulas. Why else? Things in the numerator are things we do to make the oxygenation better. The thing in the denominator is it working? So if I have a situation where of high ventilating pressures, high mean airway pressures, high FiO2s, numerator is big, but very poor PO2s, denominator is small, I'm going to have an oxygenation index that's elevated. When you start getting with an OI above 40, you can see the mortality there. Very, very poor. MAP times the FiO2 times 100 divided by PaO2. Oxygenation index. Again, there's some other contraindications that are there. I'm not going to test you on those. Just understand that it's not for every baby. And by the way, we do this on adults too. There's nothing that preempts us from doing it on peds and adult patients also. Two methods. Don't want you to know these just yet. But one is where I take blood out of the artery and put it back into the jugular vein. I said that backwards. Take it out of the vein, put it back into the artery being the carotid artery. The downside to this mechanism, and this is a mechanism, by the way, that bypasses the heart. In other words, the heart doesn't have to do a lot of the work. The downside to it is once it's done, we typically ligate the carotid artery. I don't know, somebody wanted to. And if you not, I don't know if you noticed on the one guy, he did have a little bit of a scar on his right carotid artery. Wasn't that cool though? All three of those people were in the lab were ECMO patients. Amazing. And this is kind of the system that is there. Don't expect you to know this, but basically a little pump pumping the blood. I have my membrane oxygenator there with an artificial kidney. It's an artificial lung. Runs oxygen through it across the membrane as the blood goes by. It picks up the oxygen, and I have oxygenation. We also have a veno-venous, which is a little bit less traumatic, but it also doesn't allow the heart to rest. Heart's got to do some work at this point. Got to maintain a blood pressure. Nope. I just want you to know what I told you earlier. Oxygenation index. Know that it's a mechanism by which we can improve oxygenation in patients that are refractory to everything else. And this is the veno, what you end up having. And there's all kind of things we need to monitor related to bleeding, platelet count, clotting times. If we're mechanically ventilating, we basically don't rely on the ventilator to manage much of oxygenation, maybe a little bit of minimal settings. And there's the system. That's like a kid built in his basement. Let's add this piece on. No, let's add this piece. You can see how much of a mess that would end up being. Okay. So, I don't want you to know a lot about it right now. If you want to do it, you become an ECMO tech. But ways that we can improve oxygenation, high frequency, surfactant therapy, I'm missing ECMO. Well, Jet's another one there too. Nitric oxide, thank you. All right. Before you guys go, you need to do an eval. Get this out of the way now for the final. Oh.
For a while. Still got one more.
Oh, we do go. Yeah, there probably is.
We don't have to do any more. Like this is.
What is the test?
This is our last day for you. This is our last day for the test. Yes.
Is it the day we come back?
Yes. Well, we come in Thursday next week.
Right, as far as the
Right. Yeah.
If I have it already put a steady guide up, I will make sure I get it. And what? I didn't want you to know that. Can I get a volunteer? Okay, 219. You get pen.